Okay, well, the time is 5:35, so we're going to get started as promised. To introduce myself one more time, more formally. Good evening, everyone. My name is Erica Denicola Shear, and I am the Director of Community Education and the Advocacy Coordinator for the Epilepsy Foundation of Northeastern New York. I'd like to welcome you tonight to our webinar program, Kids in School, Neurocognitive and Neurobehavioral Effects of Epilepsy. This is the third topic in a series of webinars we launched this year in collaboration with members of our Professional Advisory Board. And tonight we will be hearing from Dr. Andrew Hess. Dr. Hess is a retired pediatric psychologist who during his career worked at Sunnyview Rehabilitation Hospital, Pediatric Psychology Services for the Capital Region, and was an adjunct professor for the Department of Neurology at Albany Medical College. And he has been a longtime member of our agency's Professional Advisory Board. Before we begin, I would like to draw your attention to the GoToWebinar control panel. You should see a bar in the menu labeled Questions. If you click on the arrow to the left of the word Questions, you can expand that space and you'll see a place to type and submit questions. We are asking everyone to use this function during this evening, and at different points throughout the presentation, Dr. Hess will ask me if there's any questions, and I will moderate and read those questions aloud during the program. So please use that. If you have any questions, feel free to enter them in there. You will also see a section of the control panel that is labeled Handouts. And if you expand that section, you will see resources that have been uploaded for your use. You may download those documents to your computer at any time during the presentation, but I will also be sending out a follow-up email with handouts and probably a couple additional resources. So you will receive those by email after the program, but they are also here for you tonight if you would like to get them now. And so without further ado, I'm going to turn it over to Dr. Hess. Thank you so much for being with us tonight, and I invite you to take it away.
Erica, thank you, and it's certainly my pleasure. What I'd like to do this evening is really talk about kids in school, the neurocognitive and neurobehavioral effects of epilepsy. And those are rather long words, but we're really talking about kids thinking and their behavior in the school setting. What are the potential problems, as well as looking at some possible solutions and strategies to use with them. This original presentation was prepared by Laura Baylett, and Laura was at Nemours Children's Clinic in Jacksonville, Florida. And this was a project done by the National Epilepsy Foundation, an epilepsy and cognition project with the support of GlaxoSmithKline back in 2005. We were fortunate here in the greater capital region to receive a grant to support our being a evaluation site for the original program. We presented it in Schenectady in the fall of 2005, and again, a revised version was then presented at our Epilepsy Foundation fall educational conference entitled Pediatric Epilepsy on November 2nd, 2007. Unfortunately, the national project does not seem to have been completed. I think part of that was there was a absolutely lovely and bright pediatric neurologist who led the project, came up and did the medical or neurologic presentation here in the capital region. And within 12 months, unfortunately, came down with cancer and passed within a year and a half. And I think it was his leadership that had formed the task force, but for some reason they weren't able to complete it. And I'm using this kind of as the first half structure for the presentation, but we're going to go beyond from just what were the problems, which was the original presentation, to I think also offering some effective solutions and some solutions and strategies that will put in context what the student needs and how you can interact with school. And there is a new additional slide we put in of thinking about whether or not children and teens are going to be going back to school. And so we're going to be talking about, if you're the teacher, what can you do at home as well? Next, please. So talking about for our goals of this evening, what we want to do is talk about and understand that the cognitive deficits that are common in childhood epilepsy, and also understand how these deficits may change over time. In contrast to working with adults where their brains are fully developed, obviously our infants, toddlers, early childhood, middle childhood, and adolescents and young adults' brains change dramatically over time. And over those 20 years, how the effects of epilepsy may appear in terms of the impact of cognition and behavior change. So we want to keep that developmental perspective during our discussions tonight. We're also going to be focusing on how to ensure academic progress and access to services, and trying to ensure that we have informed parents like yourselves, educators, teaching assistants, tutors, therapists, and professionals regarding the issues of epilepsy and how it affects our students' both thinking and behavior. Next, please. Now, many children with epilepsy progress well in school. However, there's an acknowledged increased rate of cognitive problems and behavior disorders in children with epilepsy, now estimated at 80% by Chong in 2016. Interestingly, there was a book produced by Johns Hopkins, and this was in the, there were 3 editions of it. It was the late 1990s up to, I think, 2006, where basically the mantra of it was that all of our students with epilepsy were bright. Occasionally they had a little difficulties around the seizures, but they were all exceptionally smart. Well, we truly believe all of our kids are exceptionally smart, but we also know that they may have some challenges. And over the last 20 years, I think we have a much better understanding of what some of these problems may be. Now, we also have to reflect that many factors affect learning and school performance. This can be developmental stage, students' cognitive abilities, medical factors, home and school environment. We know personality factors, how malleable somebody is, how much they're willing to dig into a task, how oppositional somebody may be to accepting directions, all have impacts. Recognize students who are anxious or depressed have particular challenges in focusing and working successfully in the classroom. And there are many behaviors that either facilitate learning or can be a distraction from it. Next, please. So we must be concerned also about the adverse impact of epilepsy and its treatment, both immediately and long-term for that developing brain, and the child's ability to master critical, complex tasks both at school or in their home setting. Next, please. Now, when we think about seizures and look at the factors that may be seizure-related that affect learning that may not be treatable, some of these include underlying brain abnormality or disturbance. When this program was originally done, we didn't have the invasive neurosurgical treatments. So we're typically treating epilepsy using medications. And with that model, obviously, the type, size, and location of a brain abnormality really couldn't be changed. We couldn't change the age of seizure onset or when the youngster came to treatment, or their seizure type or epilepsy syndrome. Next, please. Now, there are some potentially treatable seizure factors that affect learning. Medication side effects, a tremendous change in 30 or 35 years over the course of my career, going from probably 2 or 3 medications that were routinely used to treat seizures, now to probably 23 to 30 that are available to the pediatric neurologist. Whether or not there is ongoing seizures, whether or not there's subclinical seizure activity within the brain, and the emotional distress regarding seizures and their treatment also can be a factor that can affect learning. And we'll talk about that in a little bit. Next, please. Now, in terms of educational issues, these cognitive processing and executive function deficits cut virtually across all academic achievement areas. In addition, children with epilepsy may have specific learning disability patterns, such as a developmental dyslexia, in addition to the seizure disorder, which may complicate it potentially by seizure characteristics. Next, please.
Dr. Hess, I'm going to apologize. My slide jumped ahead on me, so we skipped this slide, educational challenges.
Okay. Should we go back?
Yep, so let's just review this slide and then I'll go on to the following slide.
Okay, all right. My fingers always jump ahead of me, so no problem. I have that problem all the time with remotes. So in terms of educational challenges, let's break down these notions of, all right, what's cognition? Commonly, there may be attention, language, or other cognitive processing deficits seen in children with epilepsy. These may include some memory deficits, maybe executive function deficits, maybe some of the more visual processing kinds of problems. But the most common where difficulties are in attention, word retrieval, verbal working memory, verbal rapid processing, rapid new learning capacity, the ability to take information in very quickly, psychomotor speed, and executive functions in terms of planning and organization. All right. The executive function deficits, if you're not familiar with that term, relates to the area of cognitive abilities housed in the frontal lobes, and those two large lobes in the fronts of our brain. And there's been a great deal of thinking about that over the last 30, 40 years, talking about how that develops in adults and children and teens. And in areas that might be more looked at as behavioral regulation areas, you might have what kind of child inhibit a response or shift or maintain emotional control. In the more metacognitive area, which is a fancy term for, if you think of the more learning strategies areas, how well does a student do in terms of initiating, getting down to their work, or their working memory, or planning and organization of organization materials, as well as self-monitoring. Okay, Erica, take me where you like.
All right, we're back on track.
All right. So I'm going to use two areas right now to talk about looking at some of these cognitive variables. Now, when we use certain terms, all right, like attention, we all know what it means, right? But when you look at attention in a more research type of situation, or you look at attentional problems in children, be they children with attention deficit disorders, either with or without hyperactivity, or with children with epilepsy or any of the other neurologic challenges, you suddenly realize there's more than one type of attention. So if you think of the notion of focused attention, we're going to use that in the context of, if you say to a child, pay attention to me, or when teacher's speaking to what I'm saying, that's what we're talking about, the child really focusing in. And we usually use that by whether or not the child's looking directly at you, right? Sustained attention would be, now you've started, you're the teacher, you're talking about something, or you're trying to give an explanation, and their eyes are wandering, and maybe their body's wandering if it's a little guy, and it's a stay with me kind of thing. I want you to stay with the task, stay with me, stay with what I'm telling you about. Divided and complex attention is the third type, and this takes it up a notch in terms of complexity. And my best illustration of that, if you think of divided and complex attention, is if you're paying attention in class and taking notes. You have to listen to what the teacher's saying, and or possibly listen to what teacher's saying, check what she's looking at and the smart board, then write down your notes, but you can't lose track of that conversation. You got to continue to kind of track that teacher in terms of where he or she is going, write your notes, and then come back to that conversation, preferably pretty close to where you left it off, right? So it's a divided attention task. There's really a minimum of 2 things going on all at the same time, right? And finally, the focus or execute attention is, if you think of giving a student a direction, and you want to give them the direction and then you want them to do it. Focus on me, get the direction, now go do it. That would be an example in the classroom of focus and execute attention. In driving a car, you want the drivers to focus on stoplights, but if they're driving along, they see a light turn red, you just don't want them to focus on it. You want them to step on the brake, the execute component of the attention. Right? If you have any questions on that, send Eric a quick question. We'll pick that up in just a little bit. Okay, next, please. Okay. Now, one of the things I love to talk about are models of memories, but we're not going to do that tonight. That would be a whole talk in itself. I mean, it's very interesting, but once we get into the notion of memory, we're talking about 100 years of psychology of learning and cognitive science research, done often by many different scientific disciplines. We talk about models of short and long-term memory. In memory, short-term is really short. I mean, it's the ability to remember a phone number when you look it up in your address book, and can you then dial it, or if you're distracted, you realize, oops, I got to go back and get it. Long-term is everything after that, 30, 60, maybe 90-second type of episode. We also realize there's dimensions that relate to memory. There are the episodes of our life, episodic memory. There's semantic memory, which is our understanding the library of our language, all right? The meaning of words, structures and bodies of knowledge we've learned many things about. And procedural memory is more like a motor memory. How do we know how to do various specific things? Put a needle and thread in my hand and you'll see my procedural memory is not very good in terms of being able to execute a certain types of procedure. The basketball court, not so bad, but procedural memory for a needle and thread is probably not my strongest area, right? When we look at types of memory, you can talk about verbal memory, you can talk about visual memory, you can talk about motor memory, and they're processes of memory in terms of getting the information in, encoding, maintaining that information, retention, and retrieval. And we're going to talk about quite a bit about that in just a moment. And then the executive control systems. And you could read this as, what are your learning strategies? What have you invented, which is what good students do. They invent strategies to learn and remember information that were never taught to them, but they invent it seems to fit the task. For some of our weaker students, they need to be taught those types of learning strategies. How do you organize information so you can recall it later? And we'll talk a little bit about that as well. Next, please. Now, if a student is having some difficulty in attention or memory or some of those executive processes, often they'll be examined by their pediatric neurologist in the office. They may do a brief mental status exam, may see some things or may not see some things. But then we'll either look to see if the school's psychologist has done an assessment or whether or not the youngsters should be referred for a fuller, more in-depth neuropsychological assessment. Now, these approaches, the general approach to be used for any child struggling school can be the psychoeducational assessment and then the neuropsych eval, and there are a lot of overlapping components. However, the real key is that the timing of the assessment must take into account the frequency and date of last seizure, any initiation or change in the AEDs, the anti-epileptic drugs, and the doses that the students are getting. Obviously you don't want to start a full day neuropsychological evaluation when the youngster had a full-blown grand mal tonic-clonic seizure within the last 36 hours. Though if I've got a day blocked, I may ask the family, if they're not traveling too far, if they would bring the child into the office, because I'd like to see them in that 24 or 36-hour period and do a few things that I'll come back to and repeat later to see if, even if after a large seizure like that, whether or not there's still some fogginess or slow processing or memory problems 24 or 36 hours later, because that's going to be real important to be able to tell the teacher in the school. Next, please. Now, while the nature of the assessments may be different, in terms of the neuropsychological assessment, we'll spend for the neuropsych eval a greater focus on subtle language processing difficulties and verbal learning and memory types of issues, as well as issues in terms of psychomotor speed. Usually the school psychological evaluation may be an intellectual assessment, maybe academic testing, maybe a couple of rating scales. That's usually a pretty good school psych assessment, as well as an educational history. We're going to dig in. That assessment may take 2.5 hours for the school psychologist. We're going to be looking to spend about 5 hours if we can with that student on one day or many days, 5 to 6 hours at a minimum, really trying to take a look at what their learning capacities are, their strengths and weaknesses across different modalities, verbal memory, visual memory. And over the course of we're seeing the student for the day, are we seeing any subtle changes in their attention and stamina or language processing abilities? The student who, functions very well in the morning, but has got all sorts of word finding difficulties in the afternoon is telling you a lot. And obviously neuropsychological assessment, executive functions and attention and memory skills should be assessed, as well as motor speed, along with their emotional status. Next, please. Okay, so we've talked a lot, but I haven't shown you much. So one of the things I did was I pulled memory testing protocols from 3 of my students that I did evaluations on. And these profiles can get a little complicated, so I chose just a single test, and this is a children's auditory verbal learning test. It's a test in which you ask the student to listen to and to remember a list of 16 words, which is presented to them 5 times. And after you read the list to the student each time, you see how many of the words they can recall, right? So remember, we're talking a couple of minutes ago about working memory. And working memory is really that very short-term memory. So what you would do is read this list to the student, and you'd ask them how many words you remember after you read the 16 words. And you kind of mentally note their style for their ability to retell. Do they look at you startled and say, I didn't think I had to recall them already? Or are they able to rapid fire give you a whole bunch of words? Or do they struggle in terms of giving you maybe just 3, 4, or 5 words, where if you're talking about a 10-year-old, you're probably talking somewhere you expect a good 5, 6, or 7 after the first reading of that list, right? Now, the other thing that I want you to see is, when we'll go along the bottom first, that first drop-down score, that immediate memory span, is that first and the 6th trial. Now, for many tests, we're going to look at the band going up on the left hand margin. Scores between 90 and 110 are considered in the average range, right? For this children's auditory verbal learning test, and for some others, they stretch it for 85 to 115. So if you've ever taken statistics, this is 1 standard deviation above and 1 standard deviation below the mean, right? Then from 85 on this test to 70 would be the low average, cruising into the borderline range, and below 70 would be impaired. Above 115 would be high average. all right, and then superior range. So you have a sense of between 85 and 90 and 110 and 115 is average, all right, and that's the color-coded area. Then from 85 to maybe 75 would be low average. 70 is kind of borderline, and below 70, we're out more than 2 standard deviations and showing the youngster's got some difficulties. So this youngster clearly, when you look across that profile, is having difficulties in that very immediate memory span. Next, please. Now, this student seems to have just done splendidly in terms of that immediate memory span, right? And this comes from a student who I recall well, would hear the word list and just slam the pedal to the metal and try to give me as many words as they could off that list immediately. They're talking as fast as I can. I'm racing to keep up with them, and I'm not even writing down the words they're saying. I'm just coding in the number of the words that they're recalling, and I'm struggling to keep up. Now, speed is helpful for many things, but sometimes for learning it's not, because what happens is you read the list once, you read it a second time, and then trials 3, 4, and 5 are your level of learning. So you're expecting a nice building curve here and the number of words are recalled each time. Students who are using the speed strategy, right, usually stick in the maybe 6, 7 to 9 or 10 words after 5 learning trials. They're just not using any of the meaning or any of the groupings, all right, to try to put together clusters that they can remember. They have a great deal of difficulty after, and this student did as well, after you present the list 5 times, you read a new list to them. Again, 16 words, all right? And it's a little bit like a teacher who is teaching a lesson, and then the class, it's later in the day, the class is starting to fall asleep, so the teacher tells a joke, but then comes back to the material at the end, all right? So there's some interference material there, but it's supposed to arouse the class. But for somebody who's using the speed strategy, now it's a muddle, right? So they're having a lot of trouble. It's a distractor list, and they actually get a score kind of comparable to the level of learning on the delayed recall. And that profile, where their level of learning and delayed recall would say that they're not having any true memory problems, but at least in terms of maintaining the information, but they're only getting a little information in, they can't get much more out. And then the final slide, please. Now, there's some people believe kids can't have memory problems. Oh yeah, they sure can. This is a slide of a youngster who had more of mesial temporal sclerosis, and hardworking youngster, got the information in about the average range on the immediate memory span, worked hard in terms of the level of learning, did well after immediate recall, but just struggled on the delayed recall. Now you can present these slides and then you say, okay, well, that youngster's really got a lot of, just look how weak their memory is. Well, you have to take it a step further, because here's the thing, this is a test that's tapping how well people can recall information. What if we give them a list of words to recognize, all right? So if they've gotten 16 words, now we'll give them, maybe 48 or 50 words, and we're going to ask them to tell us whether or not the word appeared on the list or if it didn't. And what you find for many students is they can recall the words, or they can recognize the words just fine. What they can't do is recall it. Now that seems to be a subtle distinction, but if you think of yourselves going out to a supermarket and you meet someone who you know very well and they greet you by your name, all right? Hi, Kathleen, how are you? And you go for their name and you can't get it. It's just not there. You know them well, you know their name, you just can't recall it this afternoon. So you do the old workaround, when you're 45 or 50 plus, or even some younger, may not have been good with names, we'll do the quick walkarounds. And we know this person, we know their husband, we know their kids, we know where they work, where they live, but we just can't recall that single piece of information, their first names. All right, that's what these kids are experiencing. And if kids have difficulties with being able to retain the information, what they worked hard for, as we look across this graph, and have a normal level of memory of the material, but they can't produce it on the test, we're talking about here the difference between maybe landing a 90 or 95 on that classroom test. If it's a multiple choice or a match, but you may be landing a 65 or 70 or less if it's a short essay, short answer where information has to be recalled. One of the things I always caution teachers when you have youngsters who have difficulty with retrieval problems or any type of language processing issues is that if they do have difficulty on a test, never say to them, you gotta study harder, because they may have given you twice the amount of time studying for that test that their classmates did. But what they didn't do was study the right way for the exam you were about to give them, or you may not have told them how you were going to test them, so they just looked at the materials and put it away. And if they looked at the materials and put it away, they're not going to be able to recall it at the time needed to perform well on your test. So would you have to sit down with them and say, tell me about how'd you study? Did you have trouble with this? Maybe even make up a quick matching test and see if they can match things up. And when you realize they know it, but they couldn't produce it, then you've got the secret to success in terms of how to work with them. Next, please. Now, we're also talking about emotional and neurobehavioral challenges for students with epilepsy. Just really briefly here. Our youngsters, they throw a lot of different things at you. They may have difficulty with attention. They can be somewhat impulsive. We know some of their medications, if a youngster's on Keppra, do a great job controlling their seizures, but they may seem more irritable or have a lower frustration tolerance or tend to blow up over little things. A treatable side effect from Keppra, but you got to be aware of it to know that it's a potential medication side effect, rather than saying, oh, this is just another stage. We got to get through that, like how to get through all of the other things. They often, particularly as from middle to late childhood, 3rd, 4th, 5th grade through junior high and into high school, there can be some low self-esteem, difficulties with anxiety or some reactive depression. In some cases, there could be some aggression. They seem, if overloaded, to blow up or shut down. That's a kind of a cognitive style issue that we can talk some about. And there are some other more severe psychiatric disorders. Next, please. Now, included in your packet, a fascinating article. And I wish I could, the evening where we just kind of do as an article read, study, and discuss. Because Chung and our colleagues did a wonderful qualitative analysis study of how students with epilepsy feel. There were about 16 or 18 dimensions, and I included the Chung article in the package. You don't need higher level statistics to read this. You just read it and say, oh, wow, now I have a better understanding of how the students feel. When talking about these cognitive issues, right, what Chung and our colleagues found was that cognitive impairment, memory difficulties, and attention problems cause students to feel slowed compared with their classmates, unable to catch up, and requiring teachers to repeat things over and over. They may be really smart kids, but they feel slow, and they don't feel as smart as their classmates, right? And for older students, this perceived intellectual inferiority is discouraging. And because these students often miss school more often due to hospital admissions, doctor's appointments, these feelings exacerbate them because they always feel like they're behind. So Eric and I were talking at some point, I think a wonderful webinar would be to have folks read an article like Chang's and then come in and discuss the article and talk about, are there some commonalities with your students at home or your students in the class? All right, maybe one of our social workers could facilitate that discussion at some point. Next, please. Now, one of the keys, we're going into the phase of a little bit of what to do, but let's talk a little about comprehensive evaluations, reevaluations. For all students with disabilities, periodic reevaluations are important, but I think they're more important for children with epilepsy. Right? Early on in my career at Sunnyview, before we had insurance challenges to do this, we were typically seeing students in their mid-elementary years, before or early in 6th grade in the middle school, then toward the end of 8th grade, or in that 8th grade summer before high school, and then shifted them to the adult tests in their junior summer in high school. So they're being seen 3 or 4 times with complete batteries, but we could look at their profile and changes, look at what medications they're on, look at if their seizure patterns had changed, if for like the kids with the benign Rolandic epilepsy, if the seizures had stopped, then the question is, are they still showing some of the neurocognitive impacts from their early epilepsy, even if they were no longer having seizures? We could look at whether or not interventions needed adjustments, and frequently for students they did. You know, they might have done well with some soft accommodations through elementary and maybe even the 6th grade. By middle of 6th grade to 7th grade, we're needing to up the interventions. Maybe a 504 plan's needed. Maybe by 8th grade, you know, we're looking for some resource to consultant teacher services from the special ed department. But we can make those adjustments. And we could also feed those test results back to the physicians around any medical decisions that they may need to address. Next, please. Now, what I did here was I've taken a sample of youngsters that I've seen twice, all right? And I'll give you some sample evaluation scores from her evaluation. I first saw her as a 7-year-old, and she had a history of a concussion and seizures. She was seen by pediatric neurology here at Albany Med. Her first concussion was she was standing on a swing, reached for a bar, missed the bar, fell and hit her head. Was brought to the emergency room, but in the emergency room, she really was unconscious and non-responsive. So she got a helicopter ride to Syracuse. They worked her up overnight. She rallied, and then she was discharged home that next day. When we saw her in the office here, we were seeing scores generally pretty consistent in terms of, remember we were talking about those scores, her verbal, nonverbal reasoning, working memory, processing speed, all in the mid-80s. Visual and verbal memory really looked, you know, commensurate with her measures of intellectual ability. There were some issues in her profiling, but nothing looked too worrisome. Next, please. Now she comes back nearly 7 or 8 years later, has had another concussion, walked into a wall, and I think she was having a seizure when she just walked into this wall and went down from that concussion. Does continue to have seizures, also has now a history of migraines. And when we looked at her verbal skills, looked great. And then when we looked at the nonverbal reasoning and the working memory and processing speed, we're seeing things drop like a stone. Overall, her memory skills look pretty good. But there, in the verbal memory test, is a story recall test. And I love the test for the 12 to 16-year-olds because they use stories that are more like what you'd hear in a social studies kind of context. all right? And there are 88 idea units in the 2 stories that she asked the students to remember. She could only recall 25 idea units immediately, 20 after a half-hour delay. And when we went through a list of 30 yes/no recognition questions, she got 18. And while 18 sounds great, 15's chance. And clearly she was having huge memory problems, difficulty taking information in, and the processing speed score really was kind of the index of she really was struggling in the classroom. Let me stop here, all right? Erica, do we have any questions, or do anyone want to send in questions at this point?
So there haven't been any questions submitted about the content, but a couple people have hopped on since we started. So I will just let those individuals know real quick that I will have a recording available so that you can go back and watch the beginning. We are using the question bar. So if you do have questions in the remainder of the presentation, please feel free to enter them there, and we'll be doing pauses like this, and I will be moderating and asking your questions for you. But we don't have any right now, but of course, don't feel shy if you do have any. So please feel free to type them in now, or on the next check-in, we'll read them then.
Send them in, and we'll discuss them when we've finished the program. Okay, so now we obviously are recognizing that we've got some huge challenges here for this young lady. So let's talk about, so what do you do about this, right? What can you do? What help can I get from the school? What kind of things should I be aware of? What types of strategies should the school be using? So next, please. So let's put educational interventions in some context, all right? Many school districts introduce interventions through levels or tiers, all right? So if you think of tier 1, these are the accommodations, modifications, instructional techniques that can be implemented by the classroom teacher, right? So we'll talk about some of those safety strategies for youngsters with active seizures, disorders that are in classrooms. These are things that the teacher, the parents, the school nurse can get together and just put directly into place. There aren't needs for large meetings. You know, you want the principal to be aware, but you don't have to go through some committee process in the school to put those general instructional or health types of techniques in place in the classroom. Now, for students who need more than just teacher-based, understanding and interventions, there are 2 federal laws that apply to delivery of special education services and educational modifications, accommodations, or special teaching techniques. The first one of these is Section 504 of the Rehab Act, which is called Tier 2, typically in the districts. And if you hear of youngsters who have a 504 plan, that's what that's referring to. And then there is Tier 3, governed by the Individuals with Disability Education Act, or Individuals with Disabilities Education Improvement Act. And these are your special education services. Next, please. And the Individuals with Education Improvement Act provides categories that qualify students for special education services, such as specific learning disabilities, hearing impairment, other health impaired, traumatic brain injury. But epilepsy is not one of the categories. So other health impaired is the category that is most useful for students with epilepsy who need special education services. You can use a traumatic brain injury category, but some parents feel uncomfortable with that because there's traumatic there. It's not acquired brain injury. So at a minimum, you can use other health impaired, and other categories might suffice as well. And all children qualifying for services under the IDEA Act will have an IEP, or individual education plan. If you've got an individual education plan, then you've got special education services. Next, please. Now, the other health impaired categories, particularly useful, as I said, in obtaining special ed services, because there really aren't psychometric criteria. It's not like a learning disabilities. We have to have discrepancy between ability and achievement to receive those services. You're able to access those services directly, since there's a significant medical condition, and if it adversely affects a major life activity, which school is one, you'd be able to access those services. Now,
Dr.
if you're,
Hess,
yes,
I apologize. The slide skipped ahead again, so I just want to go back and make sure that we talk about tier 2 before tier 3.
okay, sure. In terms of educational interventions, in tier 2, these are interventions in combination with the classroom teacher, and there are modifications and accommodations. So for example, if you wanted the teacher to give extra time on tests, all right, repeat directions, those would be for students with milder problems. The 504 plan can be developed and often the first formal intervention used. And 504 plans are generally used for children who can succeed in the regular classroom. May get some remedial help as well, but require just modest modifications or accommodations. Next, please. And then, if you recall, a couple of minutes ago, I talked about seeing students in elementary school where we might just put in some classroom-based accommodations, and by middle school, maybe a middle school, a 504 plan, and then by high school, the need for a special education plan. That would be a tier 3 plan. And here, the health impaired category is particularly useful. The operational definition is OHI covers children with significant medical conditions that adversely affect a major life activity of which school is one. So if you have a student who is excelling in school, has a well-controlled seizure disorder, but completes tests without difficulties, but you would like to get some a special education plan for some reason, maybe just as a backup. So if there's a problem, they would have it as they're going into high school. You probably can't access that at that time because you have to have a medical condition that adversely affects a major life activity. If their only restriction in school is the pediatric neurologist doesn't want them to do gymnastics, right? It's probably not going to qualify for a plan, all right? But in any situations where you need a resource, a consultant teacher to work with that student, repeat directions, review materials, if they may be having seizures, as many of your young ladies do, when they're going through puberty, and they'll be fine for a while, and then for 3 weeks they're great, and then that 4th week they get their periods and they don't remember much of that week at all, or if they need a higher level special education classes or educational therapy, say speech or OT, or accommodations, modifications, or waivers. You have a student with maybe temporal lobe epilepsy, and they've got all of the MRIs are lesions in that left temporal lobe, and they're just not getting the foreign language and like that waived for a high school graduation requirement. These are the types of things you would use a special education in a tier 3 plan for. Next, please. So what might be some of those educational intervention strategies? And they can be used in tier 1, tier 2, or tier 3. So if you're sitting close to the teacher, extended time in major tests, reducing work volume, extra sets of textbooks at home. Why do you want to give them extra sets of textbook at home? Well, your little guy is forgetful Jones and he never brings his workbook home. He might need that. Opportunity to mark answers in test booklets, flexible quiet setting, pre-exam review period, particularly for students who've got some memory problems. And if you review the material just before the exam, they can remember what they studied for last night and now produce it on your test. Those are accommodations and modifications that most teachers can make without getting any additional administrative or 504 or special ed requirements. Next, please. Many of these memory interventions you can use as well. But by the time you're talking about probably intervening in memory, you're probably looking at some additional support, either at a 504 or maybe a consultant teacher level, such as use of a daily planner or agenda, daily checks in, checks out, explicit instruction, cognitive strategies. How do you learn all of this chemistry, or how do you remember all the information that's being thrown at you in social studies? How do you remember the material you've just read? Well, there are specific reading comprehension strategies such as SQ3R, which is survey, question, read, recite, review. PQRST is preview, question, read, study, and test. These are some of the comprehension strategies that you could possibly use. You may need some explicit instruction in test prep and test taking strategies. How do you study for a multiple choice exam? How do you study for an essay exam? Why is it important to organize some of your thoughts for the essay exam the night before, and you can review the cards in your pre-exam prep period and then be ready to answer the question when you get it. Can you get alternative exams or projects, extended regents reviews, presets, alternative materials, more repetition of the material? These are some memory strategies that we often find useful for students. And obviously, you try to tailor what the student needs to the task, but you also try to have a sequence of strategies that build up over time. I prefer to teach a student comprehension strategies in the elementary and early middle school, before we're looking at more heavier memory strategies for the contents that they're getting in their 7th and 8th grade. And then talking about different test strategies through late middle school as well into high school. Next, please. All right. Now, just a note of caution. There's some parents who very much want to have test accommodations for their students. And I think they're very useful for students who process information slowly. Kids who are very anxious, often you take away the quote unquote deadline. You don't have to get this done in 45 minutes, but you've got time and a half. And suddenly they can get the work done in 45 minutes because they're not worrying if they're going to meet the deadline. So there's some kids who genuinely need the test accommodations. To get them to have more time just for the SATs, that's something that really is, SAT is a speed and power test. So you're kind of monkeying with how someone might score on that test if you waive accommodations for students who really shouldn't have access to them. But it's most important to remember in these situations is that if a student has test accommodations, that they need to be specified on their IEP or 504 plan very clearly what they are, and they need to be used on routine academic or classroom tests. So if you specify that they can have time and a half or a break for every test more than 30 minutes, the student has to be using these. If a student has got a 45-minute class, but you give them time and a half, which gets them up to about an hour, 5 minutes, an hour, 10 minutes, they've got to be using that to be allowed to justify them to use them on the SATs. If you're not using your accommodations in school, but you want them on Regents or SATs, you're likely to get denied. All right. An example of these testing accommodations are extra time, taking tests in a flexible setting, or directions slowly stated and repeated. Next, please. All right, so this is the news slide. So now you're the teacher at home. Everybody, we've had a lot of students on homebound instruction. So what do you do for your own child? Well, if you have a child or a teen with a 504 and IEP, you've been through this document a lot of times. Right? Schools produce this for you potentially many times. The first place I would really go is to dig into pages 6, 7, or 8, somewhere kind of in the middle to back, is to look at the accommodations and modifications that the teachers list, particularly a consultant or resource teacher, list as being helpful for your child, and build them into your strategies for teaching them at home. I'd make sure you limit the amount of their screen time for all uses. Some of it's because I'm concerned about a seizure potential or subclinical seizures. But I also think that this produces some cognitive fatigue, and you've got to figure out how much time can they be on the computer at night with their friends playing a game, and also be then productive during the day if they have a lot of class. And this year, I think students are going to be instructed, not just given independent learning assignments, and for them to be productive within the school hours. You can provide presets, advanced organizers, reviewing previously taught material. One of the things I'm fascinated by is American history. So I put the Lewis and Clark example in there. But if you have a student, whether in middle school, and you're talking about, U.S. history or U.S. history in 11th grade, and you're kind of around the corner, or you're in Jefferson's administration, and you start talking about Lewis and Clark. And the first day, you have a delightful conversation about the youngster, about how they had their boat made in Pittsburgh. It was floated down to St. Louis. It was outfitted with all sorts of materials. The belief about the Lewis and Clark expedition was that it was a voyage into a world that wasn't known. But interesting, Lewis and Clark put together packages on their boat, little bundles, for all of the Native American settlements that they were going to meet and come across as they went up the Missouri River. So they had some knowledge of the native tribes along the river. Well, where did that come from? Well, it came from a lot of the French traders who came down the river, came to St. Louis, unloaded their pelts, and were going back up the river. If on the second day you realize, the students having just one of those fuzzy days, or maybe you think they had a seizure overnight, and they can't remember much, it's okay to go back that day and review some of the material that you taught. All right. Some things may stick. When you're talking about rivers, we think of here in Albany, we think of the Mohawk and we think of the Hudson, wide open, straight. Well, rivers weren't those ways in those days. Number one, the boat had to be hauled north because the rivers weren't straight. There were trees down across the river. There was all sorts of sand obstructions, and they were going against the tide. So the idea of Lewis and Clark sailed up the Missouri, well, Lewis and Clark may have, but the men were in the water hauling, and they had donkeys pulling on the sides as well. You want to provide strategies to structure the order of written work, do what's essential first. If it's not essential, it may not get done that day. And because if they're high school or late middle school students, you're probably going to have to keep pace to the classroom instruction. So really an economy of strategies and time is essential. Organize where work will be stored. Are it going in binders, or it's going into the computer, and how will it be submitted? Loose papers are usually found. Work that's loosely stored in a computer, maybe there may not be. We all know how that is. You work on something, you put it into a file, you close the file, and the file seems to go into some type of hyperspace. So you need to organize, because they're going to get a lot of materials this year. Following any testing accommodations that's within their IEP, or things you find that's applicable and needed by them. And remember, they're going to be sharp days and fuzzy ones, and that's okay. That's the nature of students with epilepsy and seizures. And you're not going to have somebody who's at their absolute premium at 85, 90, 95%. You're going to get some 60, 62% days, and that's not the student's personality necessarily. That may be their neurology speaking on those days, and you just have to work with what you got. Right? And next, please. All right, we've built in a number of helpful books and websites in preparing for tonight's talk. One of the things I realized, the American Academy of Pediatrics has a National Coordinating Center for Epilepsy. Wonderful resource. Take a look at it. It's relatively new. It's well funded with lots of great information, and I haven't mined it all myself yet. The Epilepsy Foundation, both locally and national, have lots of resources, and they have a seizure action plan form that Eric can tell you more about. Next, please. Included on the downloads tonight is a nice little article. Back when I think we had hoped seizure management for school-age kids was going to be a little easier than we've realized it is today. It's about 10, 12 years ago, but what it does is break down different types of seizures, certain strategies for each type, and it may be helpful just to give you an advanced organizer of, okay, let me think about my child. What type of seizures are they having? What might be some of the things we need to do? I included 2 books on this list. One is the Freeman book from Johns Hopkins. That goes back to 2002. I put it on there because if you go to Amazon or Google this topic, this book is going to pop up. There's 3 editions of it, but it really is, when you're talking about seizures and epilepsy, it's about 20 years old now in terms of the thinking, so just be aware of that. Davinsky's book is much more recent, and I think from a medical perspective, Dr. Davinsky and his group down in the city done a wonderful job, so that's very helpful. But the areas of epilepsy and cognition are a little weak in there. There was some wonderful work done by Diadana and her group in Cambridge, and I included that reference. I mentioned the reference by Chung. There's also an article by Kim that's on the American Academy of Epilepsy's website on cognition and epilepsy. A very good article, a little heavy going because it really digs into what are the different seizure types, all of them, Dravet syndrome, and some of the more catastrophic kinds of syndromes, all the way up through the various more common syndromes, from absence seizures to generalized seizure disorders, temporal lobe epilepsy, and what you might see. And I emphasize that word might in any particular child. Now, I didn't really drill this down to saying this type of seizure type will lead to this type of cognitive deficits. And the reason for that is this. When I've seen students over the years, sometimes when you see them first, they look just classic, and you say, all right, we've got a youngster with a classic pattern. And then I see him 3 or 5 years later, and the seizures are still what they were, but the pattern is not so classic. So I'm a little hesitant to say this type of epilepsy type typically leads to these types of seizure patterns. The 2 exceptions are if you have a seizure type in epilepsy where you've got marked deficits on the MRI in the temporal lobes, you're going to see some memory problems. If you have any type of abnormality in the frontal lobes, you're going to see some executive function deficits. But within those bookends, I think it's important to realize each child has to be evaluated individually. These are developing brains. We're catching these kids various years and ages, and we've got to be very sensitive to try to understand who they are, how their brains work, and how this epilepsy is impacting them, effects of any medications, their reaction to all of this, and then really come to an understanding of, all right, this is how they learn best, and how can we facilitate their learning. Well, I thank you very much for listening, and I'm all ears for questions.
And we do have a very good question. It is, how can you help the students now when they are taking virtual classes and you are not there to support them in real time?
If, let's say, a parent is working and they've got a teenager in the home and they're working on their own, what I'd probably say, the role of the consultant teacher in school, I'd adopt that role probably for the parent, is not to be by the student's side throughout the entire school day, but would be to meet with them in the morning, see what work's completed from the list from last night. Did they understand it? Ask them a few questions about things. Hopefully they're open to mom or dad, um, being a substitute teacher in this role, and you can tell them, when they balk a little bit, to say, listen, this wasn't a job I bargained for. I don't get paid by the district for it, but let's see if we can team up together to overcome this challenge of home learning. And most kids, with the idea of teaming up rather than you parent, me kid, they like that team idea. So yeah, they're a little more open to accepting some help. Then ask them if they had any questions. All right. Hopefully the teachers will give you some feedback, or give them some feedback in terms of when they submit work. Is it up to speed, not up to speed? Ask that the grade book be open so you can see how they're doing on quizzes if they're taking them online, and then starting to help them organize their work to make sure that if they're dropping it into files, that they're files that they can find and they can submit it, or they're tracking what they're sending in to the teacher, and then just if they have tests coming up, seeing if they know what type of tests they're going to get, how are they preparing for it, using some of the strategies we talked about. Hey, listen to this doc the other night. He was talking about there's some things you can do to maybe spend the same amount of time but get a slightly better grade if you use this strategy or that strategy. If they're struggling, with reading comprehension, maybe mid to late elementary or sixth grade, when the books are getting a little longer, say, there's some things we can do here that you may not, it'll take you a little more time reading, but the amount of time you're spending reading and going back and rereading doesn't seem to be getting you ahead. I got some ideas of how we can move this along and use some of those SQ3R or PQRST types of strategies, whoever would fit best for the student. And I think making it a collaborative rather than parental monitoring role may be really helpful. When you get up into the higher level math and science, it may be bringing in college students who's home, who you trust, that isn't out partying, to come over and tutor them, or maybe that could be there'd be some tutoring going on online there. So to get a kind of a big brother college guy or gal, and if the boys get a college girl, if you can, they usually will work very hard for them. Right. Probably the girls as well. You get a handsome looking college guy for some of the teenage girls, they'll get the work done.
We have another question. Other than the neuropsychological evaluation, is there any other documentation to provide the school in order to try to receive an IEP?
Well, the school can initiate that process themselves through their school psychological evaluation. Most schools will request a copy of the reports from the pediatric neurologist, so they can have a good understanding, and a medical history form actually is required as part of that initial special referral to special education. So there needs to be a written referral going to the committee. There needs to be a medical and social history. There needs to be teacher input, observation. I don't know how you do that these days if you're in virtual learning, but then some type of documentation from a school psychological report or a neuropsychological evaluation.
I would also like to just add very quickly that one of my colleagues at the Epilepsy Foundation, her name is Lori Kidd. She does attend IEP planning and 504 planning meetings as an advocate for students with epilepsy. And especially now, since most meetings are done virtually or over the phone, she can participate in those. And currently, she's our Director of Information and Referral, but she has been with our agency for a couple decades now, and previous to her current role, she was a social worker and has attended tons and tons of these meetings. So she is a really wonderful resource. So she's another person that I would be happy to put anyone in touch with if you are interested or you haven't connected with her already.
And Eric, I'd absolutely endorse that. I think one of the true strengths of our Epilepsy Foundation is your educational outreach. From Jenny Garrett to Lori now, tremendous resource for informing schools, working with school nurses, working with teachers, and at times being in school for observations if needed, working with parents so they understand the IEP processes. And it's a very collaborative process. We have some other agencies in the area that's a little more adversarial, and I think they have to advocate first. And I've always found, and this is over 20 years of working with the Epilepsy Foundation, that's why I was initially drawn to work with this organization, that they listened first and then brought a collaborative problem-solving approach to meeting the needs of kids. And it's rarely that they've had to move into the more, advocacy positions or legal positions. Their reputation is that good out in the community. And once you meet these folks, I mean, you realize they're there for the kids. They want to hear both sides. We all know that our kids can be different in school than they are at home. But they also have a way of pointing things out to the school that, this is the start of the process. This may be a type of epilepsy that isn't likely to diminish over time. So let's start small now and, build in additional, services over time. But let's get the ball rolling, make sure, we monitor and maximize the students' progress at this stage. And they're a delight to work with.
Well, thank you very much. So if there's any final questions, feel free to type them in now, but I just want to thank you, Dr. Hess, so much for sharing your knowledge and your expertise with us this evening. We really appreciate you. And on this final slide, you'll see the phone number for our agency along with our website. We're also on social media. And please feel free to follow us, check out our website. You should also receive communications from the GoToWebinar program with my personal work email, I should say. And I am very happy to take questions after this evening. You can reach out for additional resources, and we're here for you. So, oh, actually, I see more questions came in. Let me see. Okay. Okay. There's more comments. Sorry, it's all comments. Singing Lori's, saying how great Lori is. So that's good. Oh, okay. Here's another question. Do kids with this issue have hard time remembering what you have to do every day, even if it's the same thing every day? And the follow-up
Yes,
was, I have to tell my son the same things every day.
Yes, absolutely. They have huge difficulties getting themselves organized in the morning.
Okay. Thank you very much. All right. So that is the end of our time together that we have scheduled. And again, you should all have my email address. I'm also going to follow up with an email with additional resources for you. So please feel free to reach out to me. I did see a few requests for Lori's information, so I will include that on my follow-up email that I will send out to everyone tomorrow. And with that, I wish you all a very good night. And I thank you so much for joining us. And I hope that you got as much out of this as we hoped you would. So thank you so much.
Erica?